Welcome to UMCC Medical Consultant Connectors, where your health matters to us. Priapism is a prolonged, often painful erection lasting over 4 hours, unrelated to sexual activity. It's a urological emergency because trapped, deoxygenated blood can quickly damage penile tissue. Without prompt treatment, permanent erectile dysfunction can result. The name comes from Priapus, the Greek god of fertility, but the reality is far from mythical. Normally, blood flows out after arousal, but in priapism, this outflow is blocked, starving tissues of oxygen. Think of it as a compartment syndrome of the penis. Pressure builds, threatening tissue survival. There are 2 main types: ischemic, low flow, and non-ischemic, high flow. Ischemic priapism is the true emergency. Blood gets trapped, causing pain and risk of tissue death. Non-ischemic priapism, usually from trauma, involves unregulated blood inflow but is less painful and less urgent. Recognizing priapism quickly is crucial. Embarrassment or delay can lead to irreversible harm. The goal: restore normal blood flow as fast as possible to prevent lasting damage. Every minute counts. Immediate action saves function. Priapism has many causes, but sickle cell disease is a leading culprit, especially in young males. Rigid, sickled red blood cells block penile blood flow, triggering recurrent, painful episodes. Medications can also cause priapism. Erectile dysfunction injections, certain antidepressants, antipsychotics, and alpha blockers are common offenders. Recreational drugs like cocaine disrupt normal blood flow as well. Cancer, neurological disorders, and direct trauma can also be triggers. Sometimes no cause is found. Idiopathic priapism is common in adults without sickle cell disease or medication links. Regardless of the cause, the urgency of treatment never changes. A thorough history is essential to identify risk factors and guide management. The priority is always to resolve the erection and protect tissue. Priapism presents as an erection lasting over 4 hours, unrelated to sexual interest. Ischemic priapism is intensely painful. The shaft is rigid, but the glands remain soft, a key diagnostic clue. Non-ischemic priapism is usually painless and semi-rigid, often following trauma. Patients may feel embarrassed, but rapid assessment is vital. Ask about pain, duration, trauma, medications, and blood disorders like sickle cell disease. Recurrent self-limiting episodes, stuttering priapism, can warn of a major event. Physical exam focuses on penile rigidity, signs of trauma, and overall distress. A quick, focused history and exam help distinguish between ischemic and non-ischemic types. Early recognition and categorization are critical for effective treatment. Don't delay. Timely intervention makes all the difference. Differentiating ischemic from non-ischemic priapism is the key decision. Penile blood gas analysis is the gold standard. Aspirate blood from the corpora cavernosa. Dark, deoxygenated blood with low pH and high CO2 confirms ischemic priapism. Bright red, oxygenated blood points to non-ischemic priapism. Additional labs, CBC, reticulocyte count, hemoglobin electrophoresis, and toxicology, help uncover underlying causes. If the diagnosis is unclear, penile Doppler ultrasound can visualize blood flow and pinpoint arterial injuries. In ischemic cases, ultrasound shows little or no flow. In non-ischemic, turbulent high flow is seen. These tests guide immediate and long-term management. Rapid diagnosis is essential to prevent irreversible damage. Ischemic priapism demands immediate action. Aspirate and irrigate the corpora to relieve pressure and restore blood flow. If this fails, inject phenylephrine directly into the corpora to constrict vessels and open venous outflow. Monitor closely for cardiovascular effects. Most cases resolve with these steps, but if not, surgical shunting may be needed to divert blood and save tissue. Surgery is a last resort due to the risk of future erectile dysfunction. Non-ischemic priapism is less urgent. Observation is often enough, but persistent cases may require selective arterial embolization. This minimally invasive procedure blocks the abnormal artery, stopping excess blood flow. Long-term management focuses on treating underlying causes to prevent recurrence. Patient education is crucial. Early recognition and prompt care are key. With swift intervention, most men can avoid permanent complications. UMCC, your ultimate medical consultants connectors.